So the golden 15 minutes of trauma resuscitation is the topic that I'm going to dwell upon over the next 20 minutes. So might be wondering, how can you do this 15 minutes of trauma resuscitation in 20 minutes? It's quite a task. Well, that's why we are considered emergency physicians. Nothing is impossible for us. A few things to note, actually a few take-home points that I really want to impress upon over the next 20 minutes or so. You will notice in my presentation that there are certain texts that appear in gold. And if at the end of this 20 minutes, if you can recall some of those, my job would be done, really. Remember, trauma is a very common presentation, and whatever sort of seniority, whether you're a junior doctor, a very senior doctor, I'm sure each one of you have encountered a patient following trauma. What evidence base has showed over the last few years is that there are 2 or 3 very important factors that drive down the mortality and the morbidity of trauma victims. And that is exactly what I'm trying to impress upon you today. What really boils down to is, number 1, is to identifying as early as possible from the time of the primary injury to the time that you actually attend to the patient, to identify patients who are in a state of shock. And the shock most often is due to hemorrhagic hypovolemic shock. And the presentation can be, they may be in compensated state, or they may be dwelling into a decompensated state. So that is absolutely important that we identify through a very objective assessment process, and then we initiate the appropriate resuscitation. A second important factor that evidence has shown us is that early estimation of blood loss and early resuscitation with blood and blood products are probably the 2 most important aspects that we can adopt to drive down the mortality and the morbidity of trauma patients. Right, so familiar, possibly building to many of you who work in the National Hospital of Sri Lanka, and some of you who may have actually passed the National Hospital of Sri Lanka. So the image on the right side of the screen is where I'm working currently as the acting consultant emergency physician. I occupy a little space in the ground floor of this very, very impressive building. This is the Neurotrauma Center. And we actually manage critically ill neurotrauma patients. It's not always just neurotrauma. Sometimes it is polytrauma, but with an overriding neurotrauma as well. Currently, we have actually stepped up and put up our hands to convert our unit into a critical care COVID unit with the primary sort of intention to manage neurosurgical COVID patients, but because of the need of the country, we have actually stepped up to manage even complex COVID pneumonias. Right, so that having said where I'm working, on the left part of the screen is an image of the Canberra Hospital, and that is where I spent my 2 years of foreign training in the emergency department. This is a tertiary care trauma center. We see a lot of trauma. We see a lot of retrieval from varied accompanying states. They bring in air retrieval trauma victims to us. So that's where I actually trained as an emergency physician. Now, distinctly, you can notice in these 2 pictures, there are a lot of similarities, but there are also dissimilarities, right? You can see very imposing two buildings, which are nearly the same color. Now, lovely blue sky with a touch of cloud cover on both the images. But what you notice here in the picture from Canberra, as opposed to the picture from Colombo, is that you see pedestrians walking on the street. In the picture from Colombo, you see an ambulance already coming into the neurotrauma center, but you see this very serene kind of look of the outside of the Canberra emergency department. But don't let it fool you. This is a very busy emergency department with about 230 to 300 patient presentations, and every day we get pretty serious trauma victims. But what I'm trying to show you here in the onset at this very first slide is that there are systems in play, and unfortunately, Sri Lanka is, lacking that ability to conform to a system. It is a systematic approach that is absolutely essential, even when you are managing trauma victims. So you can see that there is designated parking areas, nobody is walking on the road. So system is in place and people conform to the system. And that actually improves outcome and makes managing trauma victims even easier. So ED is actually a very efficient department. Why we kind of claim to be efficient is basically because of a few things that we are very, very concerned about. Number one is preparation. And as you can see, even when we are anticipating or when we get a trauma patient, we are already prepared. And this is absolutely important if you're going to provide this initial resuscitation of a trauma patient within 15 minutes, right? So emergency physician pride on a motto, and that is what we say is, we do things slow because it's smooth, and smooth is fast, if you get my point. So if you do things smoothly and slowly, because you are doing it in a very sort of controlled way, you can actually attend to many things very fast. Okay, so preparation is paramount. And in this image, you can see this gentleman with folded arms, with a very empathetic smile on his face, and that is Dr. Dave Lamont. He was a senior staff specialist at the Canberra Emergency Department, and everybody is kind of mentor to become an emergency physician like him. You can see from the man, he's absolutely confident. He's able to manage any kind of situation. He can be a team leader, he can be a team member equally well, supporting his team during a difficult trauma resuscitation. On the background, that is one of our resus bays in the Canberra Emergency Department. Again, you can see how well prepared it is. Everything is in order. Everything that you need in managing or resuscitating a patient is available. It has its designated place. So all of these things ensure that efficiency is at its best, and this enables us to attend to our patients in a systematic way. Remember, all this equipment that you see at the back, all available even in our resource-stretched emergency department or the accident and emergency center in the National Hospital. But the difference is it systematically organized? Now that is the question to be answered. And next important aspect in managing a trauma patient is the team approach. And that cannot be overemphasized, especially when we are managing a trauma victim, because a single person, a single mindset cannot really manage everything and every complexity that a trauma patient presents with. Okay, so you need a team approach, and that team involvement is absolutely essential to drive down this morbidity and mortality when we are approaching a trauma patient. When I mean team, what I mean is it has to be a cohesive team. Every member counts. Every member's involvement is essential. Whether you're the most junior doctor or the most senior consultant on the floor, your role has to be played with the intention of making the best possible care for your patient who is in front of you. And that is absolutely essential. So your team cohesion is absolutely important. And obviously, one brain cannot manage everything. So everybody's collective decision-making assessment is absolutely essential to come about with a good outcome. Mechanism of injury is something that is always important for you to elicit. And now with the advent of a very, very well-organized pre-hospital care system in the form of the 1990 SOAS area ambulance service, this is something that is really in favor of managing our trauma patients, because these EMTs will present at the site. They are able to assess the patient on site. They are able to gather valuable information in regards to the mechanism of injury. And this can be so very important for us in the initial resuscitation of our patient. Why is it so important? Because we can actually focus on certain life-threatening injury patterns just based on the mechanism of injury, the force involved, the area of impact, and also information regarding to the site of where the patient was found. Was the patient found in a whole lot of blood, a whole lot of bleeding? Was there no bleeding at all? So all of these, even the negatives, are valuable. So mechanism of injury is absolutely essential for us to elicit. So what we must strive to do is, as part of our team approach, one of the team members should, focus on this and gather this valuable information from whichever source you can while the initial resuscitation is in progress, because this is absolutely important in our management and in making this efficient management and making this 15 minutes count, because you can focus on certain areas that you need to know whether there is any injury that might pose a threat to life immediately. Right. Okay, so the systematic approach. Now, assessment and detecting a problem and then fixing it and then moving on and reassessing, and that's kind of the second mantra that emergency physicians adopt. So our assessment has to be very objective. That is why you find emergency physicians on the floor, right? We have to be by the side of the bed because we need to be reliable with our assessment. We need to be as objective as possible, as early as possible, to make a decision in regards to the management of this patient. So we need to identify certain important clinical situations in regards to a trauma patient. These are absolutely essential. So we need to identify what is called a critical airway compromise. And the moment we notice that it is, we need to fix it. That is absolutely essential. That is number one. Number two is we have to identify catastrophic bleeding, and we need to correct it and control it with the most simplest method to be employed initially, and then decide on how we progress in that management. But these have to be identified at the time the patient presents to us. We need to identify certain immediate life-threatening conditions which are absolutely time critical, because even a few minutes that go by without us identifying it can cause a mortality or even contribute to morbidity. We need to be absolutely objective in our search for concealed hemorrhage. And when I mean concealed hemorrhage, there are so many body cavities which we cannot assess just by the naked eye, where certain significant blood can accumulate, which may go unnoticed if we do not objectively look for it or search for it. So that is absolutely essential. So these assessment parameters are very, very important when we are managing a trauma patient. Then going hand in hand with assessment, as we find a problem, we need to fix it. And that is what really entails resuscitation in this whole management principle. So we need to ensure airway patency. We need to be sure that our patient can protect their own airway. If not, we need to protect it for them. And always remember a cervical spine movement restriction until you are able to objectively rule out a cervical spine injury. And we need to ensure adequate oxygenation, and we need to ensure adequate ventilation, that we are able to remove carbon dioxide to the accepted amounts. So early commencement of blood and blood product transfusion is absolutely paramount in the management of a trauma patient. If you have found and identified that the patient has in fact lost a significant amount of blood, which is causing a clinical state of hypovolemic shock, then early commencement of blood and blood product transfusion, again, may I repeat this is absolutely essential. Right. So when I alluded to the assessment of identifying a critical airway compromise, what I really meant was two very important entities that you need to pick at the time of presentation. One is burns. If your patient was involved in a scenario where the mechanism of injury was a trauma, but the patient was also in an environment with fumes or burning environment, there's a likelihood that they can have inhalational injury to the airways. And these signs of inhalational injuries have to be looked for if you are told that your patient was involved with a mechanism of an environment in which there was a fire. This is absolutely essential. This is something you need to pick early. And if you notice any of these signs or symptoms, you need to secure this airway as early as possible, because if you don't, this is going to get compromised critically, and you're going to lose the airway, and you might even lose your patient, or you might add to the increased morbidity of this trauma patient. So remember, any burns victim or a patient involved in a trauma in an environment that is conducive for inhalational burns, you need to consider airway securing in this patient at the onset. Second thing to be looking out for is expanding hematomas in the neck region. Again, it is important and imperative that you find out the mechanism of injury. If there was a stab injury, a penetrating injury to the neck, and if you are anticipating that there is a possibility of a major vessel disruption in this area, and that leads to a expanding hematoma, that airway needs to be secured early, because if this hematoma completely critically compromises the patency of the upper airway, you're going to end up with a possible mortality and definitely increased morbidity in your patient. So that is number two that you need to identify early, and you need to act upon as early as possible. Third important thing in regards to a critical compromised airway is a patient who is having refractory hypoxia. With an increase in the amount of oxygen that you're giving to the patient, you're unable to push that saturation beyond 90%. This again is a very worrying situation in a trauma patient, and that is a situation where you might want to intubate your patient as early as possible. So these are three important aspects of critically compromised airways that we need to assess for, we need to detect early, and we need to intervene as early as possible. So managing a critically compromised airway in the emergency department is a totally different ball game from managing an airway, say, in a controlled situation like operating theater. So it entails a risk to life when you're trying to secure this airway. So remember, we need to, even in a situation of a trauma patient, and when you're trying to act as fast as you can, please do not overlook these important factors. Let me remind you again the phrase, slow is smooth, but smooth is fast. Okay, so you need to have a systematic approach. Most trauma victims may have hemodynamic compromise, right? So prior to intubation, the rule of thumb is try to achieve a systolic blood pressure of at least 80. And how do we do it? It's difficult, but we need to have some preparation beforehand to try and do this. So fluid boluses, such as 250 ml of crystalloids in the form of normal saline, or early acquiring of O negative blood, if you can, as fast as you can. In certain developed countries, we have O negative blood in our emergency department, so that we can actually go to it as the patient presents. But in our context, even at the National Hospital, I think we still have to request it from the trauma blood bank, but that can come pretty fast. So remember, if we are suspecting hemorrhagic hypovolemic shock, we need to replace, and we need to get that systolic blood pressure to at least 80 before we embark on an intubation. This concept of push dose vasopressors may be new to some, maybe some of you are well versed with this. It is actually the preparation of adrenaline in the form of 1 in 100,000. So that's very simple to make. So if you make the 1 in 10,000, which everyone knows, the dose of the dilution that you make for a cardiac arrest situation, you take 1 ml of that preparation and dilute it again up to 10 ml, and now you have a 1 in 100,000 preparation, or you got 10 micrograms in each ml of that preparation. So what you can do is, if you find that your blood pressure, systolic blood pressure, is sagging below 80, you can give 1 ml push doses until you can prop or bring that blood pressure up to just 80 or above before you embark on your intubation. So remember, HOP killers, as in hypotension, hypoxia, and acidosis, these are killers, in your attempt to secure an airway with an intention of saving your patient's life, you might inadvertently actually create a mortality in your effort. So remember, optimization before you intubate your patient is absolutely paramount and essential when you're dealing with a trauma patient with a critically compromised airway. So what do you employ? Do you employ rapid sequence induction? Do you employ delayed sequence induction? Or do you just not do anything and you just go in and secure your tube? And questions as in, is the GCS 8, now do I need to secure this airway? Or is this GCS drop due to a primary brain insult, or is it due to the hypotension? So many questions that you might have to answer before you embark on your intubation. But remember, that's why you have a team at hand. That's why you have to have access, and you need to call out to your seniors if you're really facing a situation where these absolutely important clinical decisions cannot be made by yourself. So remember, you are trying to save the life of a patient, and all these things matter, even in a situation of immense stress. But remember, once again, slow is smooth and smooth is fast. Okay. Right, so moving on to catastrophic bleeding. Now, catastrophic bleeding most often is identified at the site of the trauma victim. And you may even see this only in certain victims at first presentation to you. But now, again, with the advent of the organized pre-hospital care service that is available to Sri Lanka island-wide, and may I tell you, we should be really, really filled with pride that this service is in par with even some of the leading developed countries, and our response time is amazingly low. It's around 13 minutes, comparable to even a place like Singapore. So it's absolutely okay. I think I'm unmuted now. Can you hear me?
Yes, sir, we can hear you.
Yeah, okay. Yeah, so what is important is to identify catastrophic bleeding as early as possible. So this is what I'm trying to impress upon. So even if your patient has been retrieved without this identification, it is up to us to find this, and we need to identify this early, and we need to attend to it at the site of the patient. So very often we see catastrophic bleeding in terms of injuries to the limbs, because the vessels the major vessels that supply the limbs can be directly injured. So you have vessel bleeding, which can be catastrophic. It could be venous bleeding or arterial bleeding. So that can lead to a catastrophic state where you lose so much of blood volume in such a short period of time. And this is why it is termed catastrophic. Limb vessels, as I mentioned, can be punctured, and this can also cause catastrophic bleeding. Base of skull fracture, something that we miss most often. Why? Because we don't really see this with our open eyes, because most of this profuse bleeding that takes place from a very, very vascular bed in the base of skull is either swallowed or aspirated by the patient, depending on the level of consciousness. So something that goes undetected, base of skull fractures, but they do bleed profusely, and actually it can cause catastrophic bleeding, something that you should be concerned about when you're finding out the mechanism of injury. Scalp lacerations very often underestimate the blood loss. You can actually lose a fair amount of blood through a scalp laceration, especially if you are dealing with a pediatric patient, right? Because the body surface area, the head entails a larger body surface area, and the circulation to the scalp is so profuse that you can lose a fair amount of blood volume in a short period of time. So remember, these are important things for you to keep in mind when you're managing your trauma patient. So how do you control massive external hemorrhage or catastrophic? It's very simple. The method you adopt is the most simplest thing to do first, and then you progress with the more complex procedures as you try to control your bleeding. So wound dressing, direct pressure, indirect pressure, injecting substances such as adrenaline or tranexamic acid, packing the bleeding side, applying hemostatic agents such as gel form, and of course, the last go-to, especially in limb trauma, is the tourniquet. And this is absolutely important to keep in mind that a tourniquet can be such a useful device in limb trauma, where you can actually halt this catastrophic bleeding until you gain sufficient control, because you want to save the life. I know there's a compromise to the limb with the circulation being shut off, but remember, we are trying to save the life first, and then we can be concerned about the limb. So remember, these are absolutely essential. These are simple methods. These are fast methods that you can employ. So in your initial resuscitation, you need to employ these simple things first. And that will definitely improve morbidity and prevent mortality. Fine. Now, the identification of early shock. Now, this is absolutely important. And as you can see, that's why this the term shock is in gold. But we as emergency physicians and also doctors and nurses and other support healthcare workers in the emergency departments, we need to assess our patients as objectively as we can. So subjective assessment is not really the go-to when you're managing a trauma patient. So what are the objective ways that you can decide or decipher that this patient may be in a state of shock? Well, there are so many clinical parameters that we can think of. But what is important is we need to stick to something that is simple, that everybody can remember, and you can consistently use it again and again. I know there are grades of shock. There are grades of shock that are sort of the accepted norm, especially in the advanced trauma life support courses and teachings. But that sometimes can be a bit daunting because there are so many different parameters that need to be assessed, and there are so many variations in the grading of it and the severity. So that sometimes is not that practical in a stressful situation, and especially when you're trying to resuscitate a trauma patient within a short period of time. But something very easy to remember is something that we now employ, which is validated, mind you, as a clinical decision-making tool, and that is the shock index. And the shock index basically is a very simple calculation. You divide the heart rate by the systolic blood pressure, and you get a ratio. And what is told is if your shock index is more than 1, now that is a bad prognosticator. And that is an indicator for many, many things that you can actually objectively decide on doing, such as intubating our patient, such as activating a massive transfusion protocol, such as looking very, very carefully for concealed hemorrhage if it is not quite obvious where this patient has lost the patient's blood. Okay, so shock index, absolutely important to remember, something that can be employed, but it is not something you employ in isolation, but it is an objective assessment that you can do when you are assessing your patient. Now, delta shock index. What is delta shock index? Well, delta shock index is merely the difference if you have an objective assessment of your patient at the site of injury. If somebody, say an EMT, has actually recorded the heart rate and the blood pressure, then that is the first objective assessment of these two clinical parameters or vital signs. If that is there, and then the patient presents to you in the hospital emergency department, and then you objectively assess the heart rate and the systolic blood pressure, the difference of the two assessed shock indices is the delta shock index. And this is also a valuable objective assessor in giving you information regarding the state of shock in your patient. So if the delta shock index is anything equal to 0.1 or more than 0.1, this again is a prognosticator and a decision maker for you to embark on certain management principles. If at any time you find there's an isolated or a persistent drop in the systolic blood pressure of less than 110, this is worrying. If on objective assessment using point of care ultrasonography and using the focus assessment by sonography in trauma, or we commonly call this the FAST scan, we are able to objectively identify a collapsing IVC. This again is a corroborator or objective assessor leading to us to determine that this patient may be in a state of shock. And altered level of consciousness in the absence of severe traumatic brain injury is definitely an indicator that cerebral perfusion is getting compromised, and that is the circulation to the brain gets compromised very late on. So the compensatory mechanisms are now failing this patient, and he's heading to what is called decompensated shock. You need to act very fast. You need to hunt for the place where he's losing blood. You need to source control, but you need to, more importantly, reassess and resuscitate with blood and blood products. So these are some of the objective assessment parameters that you can employ to determine how vigorously and how intently you need to resuscitate your patient based on these factors. These are objective assessment parameters that you should keep in mind when you're managing a trauma patient. So shock index has its own drawbacks. So remember, there are certain caveats that you need to be concerned about. A shock index is not reliable in elderly patients because their ability to mount tachycardia is sometimes limited because of their normal physiological changes that take with aging. So it may not be the best go-to. If your patient is a patient who is a hypertensive patient and who is not treated well, they may actually have a blood pressure reading which really does not reflect the state of shock that they are in. So that can be a worrisome thing. If your patient is already on medications which block the heart rate response, such as commonly used drugs such as beta blockers, then you cannot solely rely on the shock index. So that becomes unreliable. But here is where, again, the delta shock index will come into play. Because if you have a comparison of two shock indices, one at the site of retrieval, one on presentation to you, you can see the difference. And then that might give you an estimate of an objective estimate that your patient may be actually heading for a state of decompensated shock. So these are some things that you need to keep in mind when you are assessing your patient in the emergency department in the most objective way, but always keep these at the back of your mind because you have to be next to your patient, and it all depends on that patient in front of you. Right. So our patients with trauma can have any one of these or a combination of all three of these types of shock. So hemorrhagic shock obviously is the most common presentation to emergency departments following trauma. So that loss of blood volume due to the forces that have worked on the body, due to the impact force, due to the mechanism of injury, and identifying where this blood loss is taking place will obviously get you thinking that, okay, hemorrhagic shock is the likely cause of shock in this patient. So remember, concealed hemorrhage has to be actively looked for. And you can do this at the bedside in the emergency department in your resuscitation. And point of care ultrasonography is absolutely important. And it is such an important clinical assessment tool in the hands of us emergency physicians and all doctors working in the emergency departments, because all it does for us, it is an additional clinical assessment tool, just like how we learn to listen to auscultate the heart and identify certain changes, such as changes in the heart sounds, added sounds in the form of murmurs, or the breath sounds. So it is a clinical skill that we gain. And now what we need to add on to our armamentarium of clinical skills is point of care ultrasonography. It is not that we are as knowledgeable as our colleagues in the radiology department. No, definitely not. I mean, they are a specialty on their own, and their input and their knowledge base on manipulating the ultrasound machine and giving us such detailed clinical assessment is totally beyond our scope. But what we do is we use the ultrasound probe in a sort of in a predetermined way to visualize what we cannot see from the naked eye, but we need to be sure that what we are visualizing is acceptable. So our ultrasound windows have to be reliable for us to get this yes or no binary answer to a clinical question. So does this patient have fluid in the pleural cavity? And because it is trauma, it has to be a hemothorax. Does this patient have fluid in the peritoneal cavity? And because it is related to trauma, it is bleeding into the peritoneal cavity. Does this patient have fluid in the pericardial sac? Because it is following trauma and a suggestive mechanism of injury, this has to be a pericardial tamponade if he is getting compromised with circulation as well. So this is how we can employ at the bedside of our trauma patient, using point of care ultrasonography to absolutely corroborate our clinical suspicion and to get clinical answers. The same goes for a lung ultrasound. We can identify certain life-threatening problems such as pneumothorax, massive hemothorax, lung contusion. All this can be identified at the bedside using point of care ultrasonography. So hemorrhagic shock, concealed hemorrhage is something that we need to look into in any trauma victim who is clinically found to be suggestive of in a state of hypovolemic shock. And if it is trauma, it has to be hemorrhagic shock if we are thinking hypovolemia. The other two entities of shock that can coexist or can be the only presentation in a trauma patient is obstructive shock. And the classic inflow obstructive shock subtypes, that is tension pneumothorax and pericardial tamponade, a very common presentation in trauma, something that we have to actively look for and to rule out if we find our patient is in shock. And finally, neurogenic shock, which is the classic type of distributive shock in a patient who has a suggestive mechanism of injury and vital sign changes such as bradycardia with hypotension, where we have to strongly suspect if this patient is in a state of neurogenic shock. So these are absolutely important for us to be aware of when we are assessing our patient in the resus in a short period of time. And don't forget to employ point of care measures. So even bedside imaging through radiology in the form of x-rays, such as the trauma series, a chest x-ray, a pelvic x-ray, cervical spine. If you cannot go on to a CT, you can still get a wealth of information at the bedside. So these are some things that you have to be concerned and you need to know about, because that is going to make a difference in driving down mortality and driving down morbidity in our trauma patients at resus in the initial resuscitation. Right. So some other pointers to think about in resuscitation, and that is what can be done in the resus itself. So bilateral finger thoracostomies is something that we go to, especially if we are suspecting traumatic cardiac arrest. Remember, this is a concept that has come about from evidence base, where we find that, going in the mid or anterior axillary line in the fourth or fifth intercostal space in the safe area directly with your finger is as smooth and fast as doing it otherwise. And evidence base suggests that this possibly is a better option if you're suspecting a massive hemothorax, a tension pneumothorax, or in the event of a cardiac arrest due to trauma. Application of pelvic binder, I cannot overemphasize the importance of doing this correctly. You have to all be aware exactly where you apply this binder. The binder has to go over the greater trochanterals of the femur, and the knot should be on top of the perineal area, and that is absolutely essential that you are aware of this simple treatment modality that can be a lifesaver, that can drive down morbidity, that can limit ongoing hemorrhage. So it's something that everyone should practice and be sure and do it if you have a suspicion that the mechanism of injury may have subjected your trauma patient to unstable pelvic fracture, even before you have imaging to confirm it. There's no harm in applying a pelvic binder, even if they don't. But if they do and you didn't, now that can lead to increased mortality and increased morbidity. Tranexamic acid, again, evidence-based, that its use is indicated within the first 3 hours of a trauma patient. There was subset analysis of the crash trials that have said there is a beneficial role of tranexamic acid in certain indications in even traumatic brain injury. But remember, you had to do this within the first 3 hours. Beyond 3 hours, its effectiveness becomes less. So the risk benefit drops more towards risk than benefit, because tranexamic acid in itself, it is an antifibrinolytic agent, and it in itself has certain risk factors. But given the context that you are managing a trauma patient in the first 3 hours, evidence-based suggests that the outcome benefit outweighs the risk. So please, it's a go-to. So it is a simple dosing that we employ in the trauma setting, even in resus. That is 1 gram of tranexamic acid diluted in 100 cc of normal saline, and that has to be pushed in over 10 minutes. And the following 1 gram goes in over a period of 8 hours for your trauma patient as ongoing care proceeds, right? So these are some of the things that you should be aware of. I'm sure most of you are aware, but these are evidence-based driven practices that we employ now in managing and in the initial management of a trauma patient. Blood and blood product transfusion and activation of the massive transfusion protocol, absolutely essential. Probably one of the most important factors in initial management, where we determine that our patient needs aggressive replacement of blood and blood products. So remember, you have to have a good rapport with the blood bank. You need to somehow or other indicate to them in advance that your patient in resus needs blood and blood products, and you might have to actually trigger the massive transfusion protocol, and that depends on your local establishment. So you best is to have working understanding with your colleagues in the blood bank and see how well you can activate your massive transfusion protocol. Now, remember, activation means you can also deactivate if you think it is not essential after you initiate a resuscitation. So it is not a crime to have activated a massive transfusion protocol and then deactivate it. But it is definitely a crime if you did not activate the massive transfusion protocol when your patient actually needed blood and blood products fairly fast for resuscitation because they were in a state of hemorrhagic hypovolemic shock. Vasopressors, and the vasopressor that I'm talking about is noradrenaline, and something that you need to start early, even in emergency department in the resus room, if you're strongly suspecting a neurogenic state of shock. Because remember, the primary insult again to the central nervous system is always the same principle. Whatever happened during the impact or during the trauma mechanism, you cannot reverse. But what we are trying to prevent is secondary insult. So oxygenation, blood supply, perfusion, same principles apply to the spinal cord. So you cannot sort of expect a good favorable outcome in a victim with a spinal cord injury if you cannot maintain perfusion. So remember, the nature of this insult, even in trauma, is that your patients will present with hypotension, and you need to prop up that mean arterial pressure to at least above 70, and you need to go for vasopressors early vasopressors even in the resus. And remember, now there is a clear indication to starting vasopressors through a peripheral line. You do not need central venous access at the first go-to. If you consider that this patient will be on long-term vasopressors, yes, then there is a place for central venous access, but definitely it's not the limiting factor to initiate vasopressor support in your patient in the emergency department. You need to get in a good IV cannula and then start your vasopressors as early as possible if it is indicated in the form of a neurogenic shock in trauma. So coming to vascular access, it cannot be overemphasized that this simple management principle is so important, not only for initial resuscitation, but even for ongoing care. If your patient is going on towards the operating theater, if your patient is going into the trauma ICU, this initiation of good, dependable vascular access in the resuscitation room will be such an important aspect in the overall morbidity and even mortality of your patient. So remember, 2 large bore peripheral IV cannula. When I mean large bore, it is 18 or upwards, and the easiest access sites would be in the cubital fossa. So you have 3 possible large veins to access. You got the cephalic, brachial, and the median cubital vein. All 3 are generally of a large caliber, and you can fit in a large bore cannula into this. So go for that, ideally on either side, but depending on the site of injury, sometimes you might have to vary the position, but always remember, IV access initially is absolutely paramount, and the earlier you get it, the easier it is, and it's going to be of most benefit to your trauma patient. Intraosseous access is another go-to when you find that all peripheral veins are collapsed, but unfortunately we do not have the proper IO device to gain access into the bone marrow, which is a huge vascular bed. And for resuscitation purposes, for initial blood sampling, and it is absolutely a lifesaver if you have the proper devices to get access into the bone marrow, which is a large vascular bed. So you can transfuse blood and blood products. You can transfuse fluid boluses, you can give drugs. It is an absolutely life-saving access into a very useful vascular compartment. The only caveat is, remember, if you do have intramedullary access or IO, intraosseous access, when you're trying to send an infusion into the bone marrow, it has to be under pressure. Simple gravity, as we normally employ sending fluids and even in blood and blood products, just employing the height of your saline stand does not work with an IO access. You have to attach a pressure bag to whatever you are trying to give, whether it is a saline bottle, whether it is blood and blood products. It has to be infused under pressure if you're going through intraosseous access, something that you need to be aware of. Right, so moving on, these concepts of controlled resuscitation in the emergency department in this initial 15 minutes is something that is absolutely important as well. These are again generated by evidence base. So what we find is that we do not want to give large volumes of crystalloids in an attempt to prop up the perfusion. The go-to is small boluses of crystalloids until we get our blood and blood products on board, because we're dealing with a hemorrhagic shock patient. So our initial goals would be to just keep that systolic blood pressure above 70 until the blood and blood products are available for us to transfuse. Remember, overzealous large crystalloid resuscitation actually is counterproductive. It actually drives up mortality, it drives up morbidity. So please be aware that you need to limit your crystalloid resuscitation even in a patient who may be having features suggestive of hypovolemic shock. You need to get blood and blood products on board as early as possible, because this large doses of crystalloids just propagate this vicious cycle that we are all aware of, that is coagulopathy, acidosis, and hypothermia. And crystalloids in the form, especially of normal saline, it adds to every component of this vicious cycle, and you drive this vicious cycle and just worsening the state of the patient. So remember, you do this very cautiously, but you need to buy time until you get blood and blood products on board. And the newer concepts that are coming up in trauma resuscitation is the role of calcium. Calcium seems to be an absolutely essential and an integral part in the coagulation cascade. You know, the bleeding in itself, you lose calcium, blood and blood products which are in the form of with citrated products chelate calcium. So there is this concern that we may be actually, kind of propagating hypocalcemia even in our resuscitation attempt. So this diamond of the lethal diamond and the role of calcium, where calcium plugs into all corners of this diagram, there is now a considerable evidence base that is being generated whether we should actually include calcium in our trauma resuscitation protocols, but it hasn't formally been introduced. So I'm just introducing you to this concept, and don't be kind of surprised if somebody tells you, let's give this patient some calcium gluconate in a setting of trauma, where there is a lot of blood products that are to be infused, and also you are managing a hemorrhagic hypovolemic shock patient. So calcium seems to be something that is looming in the horizon there, where we can actually employ in managing trauma patients in the resus in emergency departments. Right, so coming back to triggers of massive transfusion protocols, remember, to activate the massive transfusion protocol, there are certain objective parameters that you can actually assess. So obviously shock index and delta shock index is something that we can be driven by. But there are certain clinical decision-making tools that are also available, such as the ABC score, something that you can easily look up in, if you go to MD Calc, all of you guys and girls have smartphones, just download it, it's a free download, and you type ABC score, it will give you the parameters. All you need to do is enter them as you assess them objectively on your patient, and it will give you a score. And if the score is 2 or more, that is one more trigger for you to think about activating the massive transfusion protocol. And this comes into play mostly in penetrating mechanism of injury, but even otherwise, it is something to corroborate your decision. It is not the sole one, but it's something that you can add on in making your decision more easier whether to activate the massive transfusion protocol or not. Then the other concept of resuscitation intensity, how much of resuscitation and how aggressively are you actually resuscitating your patient now, is another indicator that you might want to consider activating the massive transfusion protocol. So if you're using 4 units of anything to keep that systolic blood pressure at 70, that means this is a trigger for you to consider activating the massive transfusion protocol. Okay, then the concept of goal-directed blood and blood product resuscitation is something of importance, because balanced blood products, that is in this ratio of 1:1:1. Can you just give me a moment? I might have to just attach my power source to the laptop. So sorry about that interruption to the flow, but otherwise I would have completely lost you. The concept of blood product replacement, again evidence driven, where we find that balanced blood product transfusion is the go-to in this situation. So when you mean what is meant by a 1:1:1 ratio is that the products that we are transfusing our patient is red cell concentrate, fresh frozen plasma, and platelets. And what is meant by a ratio is that a unit which is basically calculated on the patient's body weight. So blood is generally 10 ml per kilogram, FFP 15 ml per kilogram, and platelets 1 unit of platelets for every 10 kilograms of your patient. So that comprises a unit for your patient. So if you are giving one of that in blood, in that volume, you had to match it with 1 unit in that volume of FFP and a volume of platelets, which is an equivalent to your patient. So that is the concept of this ratio, which is 1:1:1. Now you immediately start giving red cell concentrate in the emergency department. And you might have to actually give about 4 units of the calculated volume in the form of red cell concentrate first. So then you might wonder, it does not matter. The most important thing to go into your patient first is the blood. You can catch up on the other components as you progress with the ongoing care of your patient. Sorry about that, I just touched. So that is an important concept, this 1:1:1 ratio to be maintained when you're transfusing blood and blood products. And generally the blood bank will just keep giving you these products in this ratio, pack after pack or box after box, because they will conform to the protocol in your institution and provide you, if you have activated this massive transfusion protocol. So it is for you as part of the team managing the resuscitation to check the products and just infuse them the best way you can into your patient as fast as you can, guided by the clinical parameters that you're seeing. So goal-directed blood product transfusion can be guided by a point of care utility in the form of vesicoelastometry, which is a concept that is in practice in most developed countries, but unfortunately, probably it's a bit of a expensive resource to have in our context, but it's something that you should be aware of. One of these is ROTAM, which is a rotational thromboelastometry, which is a go-to in resuscitation, even in trauma patients. And it's very simple, it's very user-friendly. You can do it at the bedside. It generates this simple diagram, which then you can interpret based on the shape. More objective numbers also appear on it. But for people who just are good at visualizing shapes, especially you can see the similarity that these are all the shapes of wine glasses. And if you are one of those who have a glass of wine every day in the evening, this is going to be so easy for you to remember. So the brandy glass shape is the normal shape that you would expect when there's no need for any blood and blood product replacement. The wine glass tells you that you need to give FFP because there's factor deficiency in that case. The champagne flute would say that you are low in fibrinogen, and then you need to think of either fibrinogen or cryoprecipitate, which is a surrogate that will provide fibrinogen. The test tube is if you've got thrombocytopenia and platelet dysfunction, so you need to up the platelet. And finally, if you get the inverted martini glass, that there's ongoing thrombolysis, where you might have to consider continuing something like tranexamic acid, which is the antifibrinolytic agent, to control the ongoing coagulopathy induced by trauma. So this is something that you should be aware of. Unfortunately, practically, we cannot employ this at the moment, but there's something that is always there to improve the patient care at the bedside, which is obviously going to help in driving down the morbidity and preventing mortality. Right, so I may have just stretched my talk a little long, and just to summarize, the approach is absolutely important in the emergency department when we are resuscitating a trauma patient. And the approach has to be systematic, it has to be very thorough, and it has to be team-based if you want to be successful. And my analogy is always the 1996 World Cup winning team led by Arjuna Ranatunga. Everybody played a role in that team, and that is exactly why we won the World Cup in 1996. 1996 is a very special year for me because that is also the year that I started my clinical practice as an intern, and that is also the year that I joined the Government Medical Officers Association. So early detection of shock is absolutely important. And how do you determine this? It is only through objective assessment, and the vital parameters are essential, that is heart rate, blood pressure, mean arterial pressure, respiratory rate, saturation, and body temperature. These are absolutely essential for you to objectively assess. The use of point of care ultrasonography, the use of point of care imaging, all of these things are so important to detecting shock in its earliest form so that you can start your resuscitation process early. Aggressive resuscitation, securing that dynamic compromised airway, blood and blood products coming on board early, and please work with your trauma surgeons and find out exactly where the trauma surgeon wants this patient to go into. Does he believe that this patient is going to benefit from coming into the operating theater? Please ensure that you provide him that disposition plan to the best of your ability to give the trauma surgeon the patient so that he can carry out his exceptional skills in managing this patient. Does this patient warrant trauma intensive care? Then find a trauma intensive care bed if you can and take your patient in. But if this patient is fully resuscitation stable, goes into an acute trauma ward. So remember, disposition which has to be appropriate is again the gambit of the emergency department and the so morbidity, mortality are minimized. I hope my internet connection was a little wonky. I hope you heard the last bit. All I said was the dynamic airway, early blood and blood products, and appropriate disposition is absolutely essential for a good outcome in your resuscitated patient. So finally, if there's nothing that you remember from this a bit lengthy discussion, which I didn't anticipate would take so long, I leave you with this message. This is the trauma dance. I taught my youngest daughter. She was just 4 years old. She's now a teenager and absolutely livid that I use this in my trauma lecture. But just bear with me for a few seconds and listen to what she has to say. Again, clearly, you are not clear. Come on, say clearly, darling. Long. Good. Very good. So all she's saying is the trauma dance, which I taught her, and she picked it up so well that I always thought I should use this at some point in my career if I ever get the opportunity. And that's exactly what. So what she's talking about is actively looking for these places for concealed hemorrhage and never forget all around. So that is where the EMTs play a role. So thank you very much for listening. Sorry, I went a little overboard in terms of time, but I suppose there may be questions in the chat box. So yes, I will, yeah. So I can take.
Thank you very much, sir, for that excellent presentation, and thank you for sharing with us your experience and the positive vibes that you always carry on. So we have few queries from the participants, and certain questions we have already answered. So I'll be repeating the question so that you can just get it prepared for the answers. So the first question from a participant: what is the rationale behind the correction of hypertension prior to intubation?
Yeah, so that's a good question. Rationale of correcting hypotension before intubation, because now you know that for the procedure of intubation, we have to use certain drugs, obviously to kind of sedate your patient, to muscle paralyze the patient. So all these drugs tend to suppress or depress the cardiac contractility or the functioning of the heart. So what happens is, if you don't start with a blood pressure of a reasonable amount, just the instillation of these medications are going to depress it some more, and you might actually end up with a cardiac arrest when you're trying to intubate your patient. So that is why you need to optimize these factors. That is, oxygenate your patient as best as you can before you embark on intubation, and prop up that systolic blood pressure to at least above 80 before you intubate your patient. So the go-tos are push dose adrenaline if you're really struggling, early O-negative blood transfusion or boluses of crystalloids to prop up that blood pressure before you actually intubate your patient, because you do not want to kill your patient in an attempt to save the patient's life.
Thank you, sir. At the same time, there's a question, can you explain adrenaline push dose again? Is it recommended by ATLS?
I'm not too sure whether it is recommended by ATLS, but it is a go-to that we practice in emergency departments, and it is in the hands of an experienced clinician who is aware of what exactly you're doing. Then it is a go-to that we use. But what is important is for your team members to be aware, and especially the drugs nurse, if you are going to contemplate using push dose adrenaline, then you need to ensure that you actually see how it is prepared. So may I repeat how it is done? What you do is the 1 in 10,000 has to be always prepared as part of your emergency drugs. So if you take one of those syringes with 1 in 10,000 adrenaline, which is a 10 cc syringe, which has 1 milligram of adrenaline diluted up to 10 cc, you take 1 ml of that and you dilute it again to another 10 cc of normal saline. So you have double diluted that initial preparation. So you have now a 1 in 100,000 diluted preparation, from which you can push doses of 1 ml, which constitute 10 micrograms per ml into your patient at a time for a desired effect. The desired effect is to push your systolic blood pressure to 80 or just above 80 before you embark on your intubation. So that's exactly what you do. So you need to be a clinician who is experienced in using it. You need to be double sure that it is prepared in the proper concentration, and you need to know the indication for using it and what is the end point of using it. So it is push dose. You titrate it to the effect that you want before you embark on intubation.
Thank you, sir. And the next question is, can you explain finger thoracostomy again, why it has been done bilaterally?
Yeah, so bilateral finger thoracostomy is the general go-to in a patient in traumatic cardiac arrest, because you would not know whether there are pneumothoraces on both sides causing tension. So you before you can even identify, because the patient comes into your resuscitation in a cardiac arrest. So that is the place for bilateral finger thoracostomy. But if you do identify in a patient who is not in cardiac arrest, but you do identify bilateral tension pneumothoraces or massive hemothoraces or tension on one side, hemothorax on the other side, when there's a clear indication and your patient is crashing in front of you, then that is the go-to for finger thoracostomy, because what they find is that the approach in that same area that you would embark on insertion of an intercostal drainage tube is the same way to go to using your finger. So that's something that is being practiced in emergency departments in trauma patients.
Thank you very much. So there are questions flowing from the participants. Please bear with us.
Yeah.
Question is how to suspect or identify a base of the skull fracture at emergency department?
Yes. So there again, the importance is the mechanism of injury. If you can suspect that there's been a sort of a loading impact on your patient, like a fall from height or something, a heavy object falling on your patient's head, then depending on the trajectory of impact in relation to, say, even a motorbike rider or a motor vehicle accident, right? Or obvious signs are if you got bleeding from the ear, bleeding from the nose, bleeding from the mouth, you need to suspect base of skull fractures. What I wanted to impress upon is that it can be catastrophic. It can be a catastrophic source of bleeding, because one thing, it is partially concealed because the patient will be swallowing the blood and you would not see it, and you would not see the amount of blood and the rate of bleeding. So this is why you have to be concerned until you do your formal imaging in the form of a CT brain, where you get specifically asked for a bone window, and then you can actually identify the extent of the base of skull involvement. But until then, remember, in the initial resuscitation, if you have a patient who clinically showing that he has features of shock, but you cannot find any other concealed site, but there's blood gushing down from the nose, or blood coming out, trickling out from the mouth or from the ears, remember, it could be. So something to think about in a situation where you cannot explain something very obviously, base of skull fractures, catastrophic bleeding.
Thank you, sir. Moving to next question. When should we intubate a conscious patient with inhalation burn?
Good question. As early as you have detected it, because in inhalational burns, you had to actively look for those signs and symptoms, and you have a very low threshold to make that decision, because the earlier you do it, the better the outcome. You're going to prevent a disaster, you're going to drive down morbidity, you're going to prevent a mortality. So the worst case scenario is, even if you intubate and the patient just recovers perfectly well, all you do is you extubate, right? But if you don't, you delay your intubation opportunity, you lose your airway, and then it becomes a total airway disaster. And you do not want to have that on top of a trauma patient who already has other problems compromising his normal physiological function. So remember, mechanism of injury drives this decision. If your patient was involved in a trauma that was in an environment where there was fire, where there was inhalational burn risk, remember, look actively for these signs and symptoms of inhalational burn and just make that decision and the call. Get the most senior person around to be there for you to secure this airway early.
Thank you, sir. And we have got some questions on pelvic fractures. What is the place of FAST in identifying bleeding due to pelvic fracture? How sensitive it is?
Well, I mean, you identify sensitivity of FAST is also dependent on the operator. So if you have the ability to generate ultrasound windows which have been kind of credentialed by somebody who teaches this, then your finding will be validated more or less. So if you find, depending on the mechanism of injury and the clinical presentation, and you also find that there's free fluid in the pelvic cavity or even in the peritoneal cavity, then I mean it's just a additional clinical skill that you employ to answer your question. The question is, has this patient suffered a pelvic fracture causing concealed hemorrhage, and is that is why I see the patient in front of me in resus in clinical features showing that he is in shock, in hemorrhagic hypovolemic shock. So it is just an addition for you to be more objective in your assessment. So I don't know about a number for sensitivity, but I just look at it like that.
All right. Thank you, sir. And the next question is it okay to apply pelvic binders all patients with suspected pelvic fracture, because it will increase the damage in a patient with lateral compression pelvic fracture?
Well, that is a very technical kind of question which I'm unable to answer to you. But if it is going to, I mean, if you know that it is a lateral pelvic fracture, I mean, how do you assess that other than once you get your imaging, right? So up until that time, if it is, I mean, you apply the binder based on your clinical assessment and you find that things are getting worse, then if you're going to be thoughtful in that sense, then this may be the reason. I mean, you initiated something simple with the hope that you're going to stabilize, but it's making things worse, then obviously you take it off. But otherwise, if you don't know whether it is a lateral compression or not, how would you not know? And how would you know? Can you clinically say that this is this form of pelvic fracture. So it all depends on the mechanism of injury. What is the likelihood that it could have caused a lateral compression? So it all depends. So it's again, that's why I say, so you got a trauma surgeon by your side in your trauma team. And if he tells you, look, mate, don't do this, you don't do it. I mean, you take his call because he's probably more experienced about analyzing the mechanism of injury and the clinical presentation. So what I'm telling you is, if you have a strong suspicion of a pelvic fracture, which is contributing to concealed hemorrhage and making your patient unstable hemodynamically, I mean, you need to employ it. That's what I'm trying to say.
Excellent explanation, sir. Thank you. And the next question is, which vasopressor should be used for neurogenic shock?
It is noradrenaline. There's no beating around the bush. Only in this context where there are few people who might get reflex bradycardia to noradrenaline, and that is the only situation where you might want to consider adrenaline or dopamine, but dopamine is now not considered go-to vasopressor at all. But in the context of our practice, sometimes you might have to employ it. But noradrenaline would be the first choice vasopressor in neurogenic shock. The only caveat there would be, if in certain people, it can cause reflex bradycardia. So you're starting off with a bradycardic patient, and if you're going to worsen the bradycardia, it's going to sort of confound the problem. Then you need to switch to possibly adrenaline would be my choice. Dopamine is an option.
Thank you, sir. And there are some questions regarding lethal triad. I think you have already explained this. Please go through the recorded video. Sir had given a great explanation. And the next question is, sir, what is the recommended resuscitative fluid? Is it a normal saline or lactate ringers?
Yeah, so conventionally in Sri Lanka, we still practice normal saline, but there are issues with normal saline. But we hope to negate that by being very, very cautious in our crystalloid resuscitation, because normal saline can add to the hypochloremic acidemia. So in that context, possibly Hartmann or Ringer's lactate would be a better option. But if that's basically up to the treating team, you can decide depending on availability. But it has to be a crystalloid and crystalloid alone. No gelafandin, none of those colloids, no colloids, crystalloids. That's it.
Okay, thank you, sir. And the next question is, please explain massive transfusion protocol.
Okay, so this is so what is meant by a massive transfusion protocol is, I mean, you start transfusing blood and blood products in a large quantity. So that's why it is called a massive transfusion. And the protocol is driven by your transfusion medicine experts in your blood bank. So they make a protocol as to which products come in at which stage and in what composition, but they stick to this 1:1:1 ratio. So what from a trauma team perspective, the important thing about the massive transfusion protocol is really identifying the person who needs it, identifying it early, and activating it with a good communication with your blood bank colleagues. So that is our role in the emergency department, for us to assess, to determine, trigger it, and communicate, and actually physically get the stuff into the patient. There's no point having a massive transfusion protocol in place if it does not go into the patient. So you can have breakages in that link. So if you want to optimize the efficiency to drive down mortality, to limit morbidity, the massive transfusion protocol has to work with the role of many people. And our role is basically identifying its need early and activating it appropriately and communicating with the transfusion experts and blood bank.
Thank you very much. So a few more questions to be answered. What is damage control resuscitation?
Probably you got a full dose of that from the trauma surgeon. So maybe you can watch that recording. Damage control resuscitation is a talk on its own, and the best experts to talk about it are the trauma surgeons.
All right, sir. Thank you, sir. And that's a practical question. What can be done in a major arterial injury in a peripheral unit? Yeah, so as I mentioned, the go-to would be the simple things first. So, I mean, whatever, it depends on the location, whether you're able to identify it, but otherwise the simple things first. So direct pressure, tourniquet, if that is possible. If you can find any
any sort of hemostatic agents to apply over it. Otherwise, you need to apply a suture or a hemostatic ligature. So whatever that you are competent in, but you need to do something. So you need to start with the simple thing first, and then get either, because again, the importance of managing trauma patients as a team. So you need to get the most competent person to manage it. But our role is to identify it and then do something to control it until you can do the best. So that is the concept. So it's a team effort. It's a team approach. But remember, if you cannot identify it, the vascular surgeon does not have a role, because you have not even told the vascular surgeon. Vascular surgeon does not have foresight to know there's a trauma patient in resus who needs vascular surgery. We are the triggers who need to identify it early enough and to give that opportunity to the specialist, to the person who really knows what to do with it. But we need to trigger it. We need to identify it. So that is our role as a trauma resuscitation team in the emergency department.
Thank you, sir. And the last question is, what is the best IV fluid for a neurotrauma patient? Is it a 3% saline or mannitol?
Okay, so you're talking about hyperosmolar therapy there. It's very debatable, the indication for hyperosmolar therapy. So if you are in a tertiary care neurotrauma center and you got a patient who has features suggestive of rising intracranial pressure in front of you, and you have consulted or contacted neurosurgeons, and they are just getting ready with theater to take your patient to do an intervention surgically, my go-to would be mannitol. If, on the other hand, you are managing a patient in resus in a non-neurotrauma setting, and you are maybe trying to transfer your patient into a neurotrauma center with neurosurgical capabilities, I would be very cautious in using mannitol, even if I'm identifying rising intracranial pressures. I mean, you had to, at some point, accept whether you are going to benefit this patient or not. The problem, if you don't have an endpoint in the intervention in the form of neurosurgery, is that mannitol causes a very sudden depletion of the intravascular compartment. And this can confound the problem of perfusion, cerebral perfusion, because what happens is then your mean arterial pressures drop dramatically, and now you have to pump in more crystalloid fluids to prop up the mean arterial pressure, or you might have to start a vasopressor to try to bring some normalcy. So this becomes so messy, and you, in the intention of sort of reducing intracranial pressures, you actually create a more complex situation, which can be more detrimental and harmful to the already existing primary brain injury. So I would go for 3% saline in that situation. So it all depends on clinical context, because there is no clinical evidence base that shows that one is better than the other, or the one is more harmful than the other. So that the choice is the treating clinicians and, of course, the patient in front of you that you have assessed.
Thank you very much, sir, for patiently answering for all the questions from our participants. And thanks again for your excellent lecture today. And please contributing to us in future to give such wonderful lectures, sir. Thank you very much. And I would like to thank again on behalf of GMOA and Society for Health Research and Innovation. And your token of appreciation will be sent across to you in the due course, sir. Thank you so much.
You're welcome. It was a pleasure.
Thank you, sir. And that's all the, so we are here to, ending the webinar.